So today we are having the Neurosciences Forum meeting, which is being conducted along with the Indian Medical Association Academy of Medical Specialties Coimbatore branch. And this meeting we are continuously conducting for past more than 2 years. And each and every meeting we select two speakers, and they give an expert talk. And at the end of the meeting, so what we will do is we will complete it into YouTube conversion, and then we are having all in a big file. That is what we are doing it. And I welcome you all for this program. Dr. Vikram is in an emergency surgery, so he was not able to come. He told he will come and join later. Today we have nice speakers. One is from Professor Deepak Kumar Singh from he is the professor and HOD of the Department of Neurosurgery, Dr. RML Institute of Medical Science, Lucknow. And another speaker is Dr. Nufina T A, the consultant neuropathologist from Rela Institute and Medical Center, Chennai. I request all of you to be attentive for this program, because at the end of the each session, we will be asking questions from the talk which they gave. And the winners also will be awarded. That is our protocol. Continuously, we are conducting this meeting and we are awarding the people. So, I invite the first speaker of the day, Professor Dr. Deepak Kumar Singh, to give his talk on stroke management, the challenges and solution. Professor Dr. Deepak Kumar Singh is qualified with MCH Neurosurgery, and at present he is the professor and head at Ram Manohar Lohia Institute of Medical Sciences. He has a number of publications, 155 publications, and 2 books and 7 book chapters, areas of specialization, CV junction, skull base, and endovascular neurosurgery. His achievements are, presently he is the secretary and of the Neurotrauma Society of India, and ex-executive committee member of Neurotrauma Society of India, and ex-assistant editor, Indian Journal of Neurotrauma, and chief editor, Indian Journal of Neurosciences, past section editor, Endovascular Neurosurgery, Neurology India, 4 patents of new spinal instruments, implants. He is a very pioneer in the spinal surgery.
Oh, thank you, Dr. Rajesh, for such
I
a nice.
invite Dr. Deepak Kumar Singh to give his lecture on stroke management challenges and solutions. Welcome you, sir.
Thank you, Dr. Rajesh. It's such a nice, nice that you have spoken so many good words about me. And it's my privilege that I have been associated with you for past 2 years. We both, me and Dr. Rajesh, are working in the Neurotrauma Society of India right now. Dr. Rajesh himself is the treasurer of this national society, and both of us are actually trying very hard, for the upliftment of the national society. And I want to thank him to give this opportunity to me, because it gives me a platform, to interact across, all across, right from north to south, and it's very nice. And thank you, Dr. Rajesh. So today I am going to share my views of stroke management and what challenges we are facing as Indian physicians or Indian neurosurgeons. So this topic is a mix of, the scientific thing and the philosophical aspects also, including the financial aspects also. And you will get to know what challenges we actually are facing on day-to-day basis when we are dealing with a case of a stroke, especially the ischemic strokes. So let me share my talk. So stroke management challenges and solutions. That talk I have delivered, like 2 years before in a IMA meeting, in the National IMA Society meeting in Delhi. And today I got an opportunity with the revised scale to present before you guys also. So what is a stroke? So what is a stroke? Stroke is basically defined in 1970 it is defined, if it is defined way ahead of the time in 1970 by the WHO, and is defined as rapidly developed clinical signs of focal or global disturbance of cerebral function. It lasts for more than 24 hours and may lead to death, and the cause is always vascular. So that is the stroke. And if it is transient, then we define it TIA. So definition of TIA was given by American Stroke Association way back in 2008 or 9. And if you see in the stroke part, the spinal cord or retinal ischemia was not included, but in TIA, if it recovers within 24 hours and the origin may be of the brain, of the spinal cord, or it can be solitary retinal ischemia without acute infarction, and it usually subsided within 24 hours. There is a complete recovery. So by definition, it is transient ischemic attack. It can be of brain origin, it can be of spinal cord origin, or it can be simply involving one of the arteries of your eyes. And symptoms, we all know the mnemonic we are learning for so many years, that is FAST. That is any weakness on your face, arm or leg or extremities, any slurring or speech, that is the basic pneumonia. And if you have any problem in any of these, you have to act very fast. Then time is the brain. We call it time is the brain. So fast mnemonic in Hindi, they have given it a name in the new national guidelines by Bachao, or in Hindi they are also saying it's like any problem in dekhna, dikhana, haath, pair, bol or chal. So we have to remember the fast thing. And if you go by for the disease burden, it is the second most common cause of death globally, second to the ischemic heart disease among all non-communicable diseases. And disability adjusted life years, if you see, it is the third most common cause. And in India itself, if you see the numbers, this is like growing day by day, and it's approximately 150 cases every 1 lakh population per year. And one of the all 6 Indian is at risk if you see this. And surprisingly, to my knowledge, we, especially all, the physicians, the neurosurgeons, or the people who learned people, they are not taking any precaution, and they are not aware how to calculate the stroke risk. You must also be not knowing that there are several stroke calculators available. One is when calculated by the WHO way back in 2000 itself, 2002 itself, but we are not knowing the name. And the name was mystroke-risk-calculator.com. When I was preparing this preparation, this preparation for 2-3 years before only, then I came to know there are several scales in which, by putting your weight, your genetic morphology, your origin, your lipid profile, your family history, you can get a rough estimate of developing stroke in subsequent 1 to 10 years. And we are not aware of this. And surprisingly, it is taking one life in every 4 minutes. So the disease burden is huge. And if you go to the major risk factors of stroke, the non-modifiable risk factor, you see this list, the non-modifiable risk factors are very low, very few in numbers. There are only 6: genetic factors, increasing age, low birth weight, ethnicity, your financial status, and male gender. You can't do anything about it. But what about other things? You see, the list is so huge of all the modifiable risk factors, be it your hypertension, diabetes mellitus, your lipid status, obesity. There are so many modifiable risk factors that you can actually change and get free from, you can reduce the risk of stroke by large margin. So what you can do for that? One is the primary prevention of a stroke. So it is based on high risk strategy or population based. Population based is run by majorly the PSCs, CHCs, and the district hospitals all across the India, and Asha Bahus and Ashas and ANMs, NHM, they are all given responsibility. But I am very sure that nobody is taking their responsibility seriously, especially in the PSC and the district hospital. That is a problem. Because if you go by the list, I'll show you the list. The government of India actually has allotted them a huge task of identifying the problems that lead to stroke, but nothing is happening on the ground. That is one problem that we have to look for. So, and second is the high risk strategy, especially in the metros, or if you are associated with or a tertiary care hospital, then high risk strategy can be taken care of. The problem gaps are there is lack of awareness. I'll show you how there is lack of awareness. Under usage of population wide strategy, just because the failure of the CSC and PSC that are working on the ground level, and false reassurance of low risk management of blood pressure. Nobody is taking their blood pressure on regular basis. Nobody is measuring it. And there is no CVD prediction algorithm that is India specific. All the scales that are used are made way back in 1960, and that was the famous Framingham heart study. So it was done way back for the Mexican people and the white Caucasian, white Hispanic people, but no India specific scale is still available in India. That is the problem, and we are not aware of any of the riskometer apps. And there are a lot of apps on the Google Play itself, or the Apple. I mean, you can download any of the apps, and they are all good enough, and you can actually measure your stroke risk for next 10 years. And obviously, the cost barrier is one thing. So coming to this, so a pharma company known by name of Boehringer Ingelheim, this is based in the south itself. They have done a very wide study in the 12 major cities, 12 metro cities, Bangalore, Chennai, Delhi, Mumbai. They have included 12 major cities, and the sample size was 4,000. It was in 24, it was like 18,000. The sample size was increased to 18,000, and you see only 22% are aware of risk factor. This is happening in the metros, and only 10% are aware of the treatment options. So if this is happening in the metros, you can just assume what is happening in the and in the village level. Nobody is knowing about this. The impact of media is very less as far as this stroke thing is concerned. People are more aware of cancer and other things. They are aware of, but regarding stroke, how to prevent it, or if something happens, to whom they should contact, they are not aware of it. So that is a problem. And this list that I was asking, that I was telling you about a few minutes back, that is the list, that the task that was given to the Asha Bahus and the PSC CSCs people, how to identify the risk factors, early identification, and the prevention studies. But I'm damn sure nothing is happening on the ground, because in my institution itself, they have taken a community center and nothing is happening on the ground. So that is the reality. And exercise. So in the childhood especially, the children are not aware of their habits, especially the eating habit and sedentary habits. And a study that was done and published in 2021 has linked the childhood obesity is associated, clearly it is associated with high risk of ischemic stroke. So it is not only that if you change your dietary habits in adulthood or later in life that you will get rid of a stroke risk. It's not happening. It's not like that. It doesn't work like that. You have to be very sure about your the dietary habits of your children, their sedentary habits right from the start, because childhood obesity has a direct link with the ischemic stroke, especially the large vessel occlusion. Surprisingly, it was not associated. The study has said that it is not associated with the hemorrhagic stroke, but the ischemic stroke association is very strong. So good habits should start very early. And you must not be aware of this also, that government of India actually in a Fit India movement has prescribed the fitness protocol for all the people. I was also not aware of this. When I have gone through it, they have specifically described the fitness protocol for people ranging from 5 to 18 years, then 18 to 65 years, and more than 65 years. And it is a very beautiful, PDF file that is available on the Government of India website. You can just Google it. And you need not to go to any specific physiotherapist or specific, the protocol type of thing. You can simply download it, and every exercise has been explained so easily in this PDF. And with a YouTube link, then you can actually practice and let your children practice, let your society and community practice this. I was not aware of this, that the Government of India has made this. So I am putting it before you so that you also become aware and you can give it to your patients also. The another thing that as a doctor we can do, So there was a famous study that was published in 2008 by known by name of KIDS. That was Kids Identifying and Defeating Stroke. That was known by name of KIDS. So what they have done in Mexico, the American, the Texas and the part of Mexico, they have started this program that is called KIDS, in which they have trained the middle school going children about the risk factor associated with stroke, and how to identify stroke and when to respond. So what happened if you just assume what is happening in household also? Your children who are in class 6 to 10 or class 6 to 12, they are the people who are associated with your grandparents, the people who are at risk. So they are the people who are, in your home for most of the time with persons at risk. So if they know how to identify and how to respond if something happens to their grandparents, the response time or response rate will be definitely high. So what they have observed, the response rate in these areas has significantly increased by 35%. So why we can't do it? If our children are, studying robotics, the computer science, I mean, every type of difficult subject they have been put through, but not they are not being taught about, the basic life sciences resuscitation courses. They are not being taught about how to identify a stroke and when to respond and when to call, the health services. I think the government of India, and I have given a presentation before the government also here in UP, but nothing has happened so far to include, the simple prevention strategies for non-communicable diseases in their course module. That can be added. It's very simple, fast, how to recognize, especially in their grandparents, and they can respond, and the response rate be quite high. So that is one thing that as a community, that as a physician, that as a society, we can put pressure on the government to do, to include this into the basic curriculum for middle school age going children. And as I have said, take physical education very seriously. Media coverage is important, and time is brain. That is one thing also that I am focusing right now, that the people who are developing stroke mostly belong to two groups. One is diabetes and one is hypertension. So why can't we put, everything on the wrapper of the drugs itself, and a number to whom they should respond with the symptoms on which they have to respond. If if they get it like every hour, every morning and evening, if they study it, like if there is any problem in their facial asymmetry, their arm weakness, speech, and if something like that happens, to whom should they contact? If they get that information on their drug wrappers itself, drug packets itself, the response rate will be quite higher. So that is one thing that we can ask the pharma companies to do, to put, the symptoms of the stroke, developing stroke, the TIA, on the drug wrappers itself, and give them a centralized number, that how it is happening for the STEMI program. Okay, it is STEMI program is running all across the India right now for ischemic heart disease. Similarly, a program can be run for, the stroke prevention also, and it can start from here, from the packets of the drug itself. So that is also one thing that as a society we can do, and we can ask the government to do. So recommendation, there are a huge set of recommendation for preventing hypertension, diabetes mellitus. I'm not going into the detail because, every physician is quite well aware of it. And tobacco use, obviously it has to be seen. And if the patient is having atrial fibrillation, mitral stenosis, carotid, the carotid diseases, it's different set of treatment, and the preventive strategies has to be applied for all these subsets of patients. So this is beyond the scope of this talk, but this all are high risk group, and they have to put on some sort of anticoagulation to prevent the stroke happening. And for every detail, you can go to specific government of India website, and everything has been described beautifully. And obviously, the lifestyle management is the most important thing that you can do. So this is a small video how you can do carotid stenting. For carotid stenting, if the patient is symptomatic and the stenosis is more than 50%, he has to be put on blood thinners. either ecosprin or clopidogrel for rest of his life. And the recommendation right now, if the stenosis is more than 70%, so it has to be treated by neurosurgeon or a intervention radiologist or intervention neurologist, and some sort of treatment is mandatory if the stenosis is more than 70% and and uh, and the patient is symptomatic. So what we, as an endovascular neurosurgeon, what you can do, you can put the stent inside. So that's how the stent is being placed. You see the ICA is severely stenosed at the origin. So we are passing a wire through it, and the filter is coming up. You see my guiding is at just below the common carotid bifurcation. The filter is going up. The filter is placed in the petrous ICA, and see how the stent is going up. It's about self-expanding stent, and that is how it is being opened. And you may require to do balloon angioplasty after that. So that is how the carotid stenting is done in cases of carotid stenosis. So coming to management part, it involves the early management, and if the stroke has happened, if it has established and you can't reverse the things, then there is separate subset of management that you have to adopt. I have talked about this fast. So any patient who presents with transient symptoms suggestive of cerebrovascular accident is considered to have a TIA unless neuroimaging reveals that there is TIA mimic or there is alternate diagnosis, and he should be submitted to any CT, MRI, or vascular imaging. And for TIA, he has to be immediately given 150 mg aspirin and 300 mg of clopidogrel stat, and that has to be for first 3 weeks, and that has to be followed by either aspirin 75 mg daily or clopidogrel, depending on the ecosprin resistant. Sadly, almost 40% of Indians are ecosprin resistant, and the resistance measuring mechanism is not available widely. So if you are using aspirin as a preventive strategy, be very, very careful. And if the patient has to take aspirin for long, so it's advisable to check for the aspirin resistant before submitting him to this treatment. It is advisable, but I understand it's not available widely, so it is a problem. So for early management, all patients having TIA which is less than 24 hours of duration or is evolving, is progressing, they should be admitted. So first thing, if it is of less than 24 hours not subsiding, then the patient should be admitted. Okay, and the risk of subsequent stroke in this subset of patient is very high. So if any patient who has gone through the TIA, you should be very alert, and you should start the treatment, because this is the population that you can save, because 1 in 5 patients are going to have stroke, heart attack, and they will die within 1 year. So 20% of these people actually die because they are not submitted to the preventive strategies to treatment. So if he has having TIA and is less than 24 hours, the guideline is that you should admit this patient. That I have talked about what the treatment should be given in TIA. What is the crescendo TIA? The crescendo TIA is 2 or more episodes of TIA in 1 week of time. You see the last line of this slide. Only less than 1% of the TIA report for evaluation. That is the problem. Because it happens and it resolves. So they don't report to you. And 20% of these people eventually will die. So you have to identify that subset of patients. And how can you identify? When you actually spread the awareness, make them literate about the symptoms of TIA and what it can cause to their life expectancy. So this is a treatment protocol. We all are aware. So if the stroke symptoms are there, the patient has to be admitted. You have to go for a CT scan. And if the patient is eligible for thrombolysis, that I'll come, if the patient is eligible for thrombolysis, and if there is no other TIA mimic, there is no other cause, you have to put him for some sort of treatment if it is evolving. If it is resolving, you simply do the TIA treatment that I have spoken before. But if it is evolving and patient has reached to you within 4.5 hours, you have to immediately give him the clot dissolving drug. And what is the clot dissolving drug? That is RTPA. Okay, tissue plasminogen activators. So what two drugs that has been approved by DCGI is, one is altiplase and second one is tenecteplase. So altiplase is given in form of infusion, that is 0.9 mg per kg body weight, and 10% of this should be given in first 10 minutes and followed by a 60-minute infusion. And tenecteplase is given 0.2 to 0.25 per kg body weight in bolus injection. So one is infusion, one is bolus. Obviously, the tenecteplase news drug and its cost is quite low. Then the altiplase costs like 40 to 50K, and similarly the tenecteplase costs like 20K, 20 to 25K, so it's almost half. So what is the evidence? So the class 1 evidence is in the favor of intravenous RTPA, and all the patients who are eligible, who come to you within the first 4.5 hours and are having symptoms and radiological imaging suggestive of ischemic stroke, they should be given RTPA. And but it's not the end of the story. If the patient doesn't come to you in the 4.5 hours, what you should do? So if it comes to you within the 16 hours, there are two studies, very, well acclaimed studies. One is diffuse trial and one is dawn trial. So what it has said, that now the time of mechanical thrombectomy, the time in which you can go and remove the thrombus, has extended up to 24 hours. The diffuse trial has extended it to up to 16 hours, and now the dawn trial has extended it to 24 hours. But what are the guidelines for that? You see, the diffuse trial said that if the NIHS score is more than 6, the NIHS score is a basically symptomology based score. If it is more than 6 and the core volume, the infarct core volume is less than 70 ml, you can do the mechanical thrombectomy. So if the part of the brain that you can salvage is more, is quite more than the part that has actually died, you can still submit the patient for mechanical thrombectomy, because a lot of part of brain is going to be saved. But for that, you need to have a perfusion CT or perfusion MR, so that you can see what is the part of the brain that has not died and that is hypoperfused only. That what we call is penumbra. So if penumbra is large, the part of brain which is at risk but has not died, you can still submit that patient for mechanical thrombectomy for removal of the clot up to 24 hours. But for that, you need to have your CT perfusion studies or the MR perfusion study to actually estimate the core volume. But the problem is, this data is taken in 2022. There are only 3,000 CT scanners in India. That count has now increased up to 4,200. But still, if you're considering the huge number of people, that is still very less. And radiologist, only one radiologist is available in 1 lakh population. So what is the solution? The solution is you have to increase the network-based reporting, because you cannot make availability of radiologists in every nook and corner of the India. It's not possible. And who is going to read these CT scans in the middle of the night in the villages? And you can make CT scans available every nook in every part of India, but who is going to study them? Who is going to study that there is a hyperdense MCA sign or there is a SAH in one of the top cuts? Nobody can see. The MBBS doctor who is posted there at the village or in the district hospital cannot read it, cannot interpret it. So that is a problem. And how many people can actually perform a lumbar puncture to rule out that there is a subarachnoid hemorrhage? It's not possible. So you have to give good incentives to radiologists for network reporting that is available, that you have to make available for 24 hours. That is one thing that as a government, as a government of India, or at a state level, the governments can do. So the two clot dissolving that drugs that I have I have already talked about. One is altiplase and second is the tenecteplase, and the doses already have been talked about. If you want to download the calculators, they are already they are available on the Google. You can download the calculator, in which by putting the weight of the patient itself, you can get every information. So apps are already available for that also. It's very easy right now. Okay. And so why have I have put this image? So see, if we subject, I mean, every eligible patient for IV thrombolysis, and if everything has been given free of the cost, so what cost government of India is going to pay? That is only of three and a half Rafales. It's very less, actually very less. It's not a big deal. So this is about every patient, not only the patients who are being admitted or who are reporting. This is about every patient. So if every patient is an eligible patient, and if we are giving free treatment to every patient, then only the cost will be only of about three and a half Rafales. It can be done. So what I'm trying to convey, that it can be done. It's not a big deal. You see, the budget, it is reducing day by day. In this budget, it was like 0.6% again. But if you see in 2022, it was 0.6, then 0.42, then 0.36%, and now only 0.35% in 24. Now it has been again increased, and it is 0.6%. But considering the number of people we are catering, this is one of the worst budget estimates that we are going for health. That is also a problem. So, and about the Ayushman, the famous Ayushman scheme. Surprisingly, the government of India has put a very good amount for clot retrieval in the Ayushman scheme. But the problem is the Ayushman itself take for from 6 hours to 24 hours, depending on the situation, to activate. And by that time, your window is lost. So it's not pre-activated. That also is a big problem. We have raised this issue so many times that the Ayushman cards should be pre-activated so that the patient should be benefited. Otherwise, there is no benefit of putting this intracranial thrombolysis segment or clot retrieval segment in the Ayushman scheme, because the time is already lost by the time the Ayushman card is activated. So that is also a big problem. And that we have talked about. So on the left, this is one of the catheters that is used in mechanical thrombectomy. And as I have said, only one radiologist is available on 1 lakh persons in India. And coming to endovascular surgeon, that is approximately is one endovascular surgeon is available at 35 lakh people. So competence is again a big task that gap we have to fill. So coming to TPA. Now the problems of TPA. It results in recanalization in only about 50%. Okay. So 50% of patients are only going to be benefited, and in rest, you have to submit him for other type of treatment like mechanical thrombectomy. So mechanical thrombectomy again is not successful in all cases. Why? You see, these are different type of clots that you encounter when you are going for a mechanical thrombectomy or clot retrieval, right from a red clot to a white clot. So what is red clot and what is a white clot? Red clot is primarily made up of RBCs, where the white clot is primarily made up of fibrin. So if you are going to do mechanical thrombectomy or mechanical removal of clot in RBC-rich clot or red clot, it is very simple to remove, but the problem is that it fragments and it causes, because it is very soft, it fragments and it causes distal embolization. And fibrin rich clot, though they don't embolize further, but it sticks to the wall of the vessel, and sometimes it becomes very hard to remove it by using stent retrievers also. So both have their pros and cons, and you have to learn to deal with this RBC rich clot or the fibrin rich clot over the time. The CT scan gives a rough estimate about what type of clot you are going to deal with, because if there is a hyperdense MCA sign or hyperdense basilar sign, where MCA or basilar you can mark out on a non-contrast CT scan, that basically is a RBC rich clot or red clot that is simple to aspirate, but the chances of embolization are higher. So in that cases, if you are suspecting that I'm going to deal with a red clot, it is always advisable to use a balloon guide rather than a simple guide, because the balloon guide you can inflate the balloon in the common carotids or in the ICA, and you can actually seize the flow and you can aspirate, so the chances of distal embolization are very less. And if there is no, this hyperdense signs, then chances of you getting a fibrin rich clot is very high. But most thrombi are mixed. It depends. So impact that we have talked about. So coming to techniques, there are two common techniques that you adopt during mechanical thrombectomy. One technique is called adapt, that is a direct first pass aspiration, a direct aspiration. And second is SOLUMBRA. The SOLUMBRA technique is stent retriever along with aspiration. So this is how you do both the techniques: a direct aspiration first pass technique, that is adapt. So this is a demo video. That is how you take the access of your carotids. See, the guide is going up along with your catheter, and then you are taking a run to confirm that inside your vessels. That is how you shape your vessels first in the subclavian trunk, and then you get access to common carotids. You must be aware that these people are usually in their 60s or 17, and you are going to encounter a difficult arch, mostly type 2 or type 3 arches in all that cases. And sometimes it's very difficult to cannulate the common carotid, and you should be experienced enough, especially you are dealing with a stroke, because time is passing, and you have to be very fast. So experience is one thing that you should be looking into, and that is how I'm just forwarding this, and see my stent is going inside the blocked MCA. This is a demo video, and I'll show you the real scenarios also. Okay, then you open up you give a microcatheter injection to confirm that you have passed the clot, and then you put your stent, aspiration catheter first, because I'm showing you the adapt first. So this is the aspiration catheter. And you are aspirating. The aspiration time is 90 seconds to 2 minutes. Beyond that is not going to work. Okay, so syringe shows that you are aspirating using a 50 ml syringe. In Western countries, they are using a 60 ml syringe, a standard 60 ml syringe for aspiration, but in India, we are using 50 ml syringe. And so the angio shows that superior division is open, but still the inferior division is not open. So now you are putting your stent retrievers, same route. The micro catheter is going inside. You have opened up your, the stent is opened. You can see the 3 dots, and you can remove the clot. And then you under negative section, and then you give the contrast, and all the vessels are opening. So that is how you do it. Okay, so coming to a real case scenario, this is one gentleman that I have operated upon like 2 or 3 months back only. So it's a very fast video that I'll show you. See, one side MCA is cut off. So Sophia is going up. Sophia is aspiration catheter that is going up. Okay, and Sophia is in place, and I'm aspirating, and by simply aspirating, the clot is removed, and then you see the run. it is open. It is all open. So you achieved a very good recanalization by adapt technique also, or you can do a SOLUMBRA technique. This is another patient. The SOLUMBRA is by using stent retriever, you can remove. So in this patient also, we first tried to remove it by aspiration, but unfortunately it was not opening up. So a Trevo stent retriever was passed, and a Trevo stent retriever was passed. In fourth pass, it was partially opened. Then we did a second trial with a stent retriever, and you are going to see the final run. And this is the final run after mechanical thrombectomy. And that was opened up into the sixth pass. So it took quite a time to open up, but we get very good result at TICI 2B recanalization. So I'll show you what is TICI recanalization. So these are the two basic techniques that I have just talked about. That one is aspiration and one is stent retrieval. So aspiration is good for RBC-rich clots or red clots, and stent retrievers are better than aspiration in fibrin-rich clots. But again, you have to mix and match, and depending on your expertise, you get to know what type of technique you require during the actual surgeries. So this is the thrombolysis. This is the TICI grade, that the recanalization that you achieve after your mechanical thrombectomy. So in TICI 0, there is no recanalization. In TICI 1, only proximal part is recanalized. In TICI 2A, less than 50% of the MCA supplied territory is opened up. In TICI 2B, more than 50% of the MCA supplied category is opened up, but it is not the complete recanalization. And TICI 3 is the complete recanalization, including the cortical flush. So the aim of your mechanical thrombectomy is always getting at least a TICI 2B recanalization, but obviously it's not possible all the time, and you become successful only in 50 to 70% of the cases in most of time. So this is again one case in which I have to put a stent also, in which the basilar trunk was gone. The patient reached to us in only 2 hours of time. In that case, we did a balloon angioplasty after mechanical thrombectomy, and then we put a stent also, and it was, the end result was very good, and that patient was discharged and tracheostomy, and that was the photo sent by one of his relatives after 2 months, and he completely recovered. So it's heartening to see that these patients actually recover very well if you put effort during the thrombectomy itself. You need not to lose your hope, and you should keep on trying, because even after so many things, so many problems, and after duration, the end result somehow is quite good in these patients if you become successful during recanalization. So for surgery, so this is one part, the endovascular part. Then coming to surgery in ischemic stroke, if more than 50% of the MCA territory is involved in infarct, and the midline shift is more than 4 mm, they have, or the core itself is more than 145 centimeter cube, they have to be submitted to decompressive craniotomy for salvage. And if there is large cerebral infarct that is causing compression of the brainstem and altered consciousness, then also the patient should be subjected to suboccipital craniectomy. You need to remove a part of bone to give the brain space to expand. And for hemorrhages, if it is more than 3 centimeter in diameter, especially the posterior fossa hemorrhages, it should be removed, and EVD alone should be avoided. So the take-home message: if you find a cerebellar hematoma with upstream hydrocephalus, I don't put EVD alone, because it's not going to work. The compression of hematoma is there, and you have to remove the hematoma. And if there is symptomatic hydrocephalus, obviously you have to remove, you have to put do some sort of CSF diversion process. For supratentorial ICH, also the same philosophy, within first 72 hours. And if there is someone to take care of that patient at home, the guidelines are that you have to submit these patients to decompressive craniotomy along with hematoma removal if possible at all. And different systems have given different type of measurements for these type of patients. But if the hematoma size is more than 8 centimeter, you have to remove these hematomas also, and especially if it is on the right side, because the right side hematoma, they are going to make a good progress. They are going to, sometimes they are going to lead a normal life, because their consciousness, their speaking ability, their understanding ability will be preserved, especially in the right-sided hematomas. So these patients, if they are having right-sided ICS, they should be managed aggressively. So after ischemic stroke, I'll talk only in 2-3 slides about the hemorrhagic strokes also, in the subarachnoid, about the subarachnoid hemorrhages also. This subset constitute of like 2 to 5% of all the stroke patients. So if you encounter any patient who's having aneurysm, obviously you have to, take any of uh, treatment methodology in form of open surgical clipping or endovascular treatment. This is one case of choroidal artery aneurysm, a giant one that was clipped, and or you can do simple coil, or you can put a flow diverter. It all depends upon the morphology and the location of the aneurysm itself. And you can, now there are a lot of intrasaccular devices in which you need not to put a stent or an external device. Everything inside the saccule of the aneurysm itself, that are called intrasaccular devices. In India, they are a contour device and a web device that is being used. A lot of other devices are coming up to the market, and I'm pretty sure that they are going to change the scenario. That will be the last slide, the rehabilitation. This is the most ignored part, especially in the rural setup or the towns. And you see the rehab services are available only to 50% of the population, only 50% of the population. And only 1.8% of the survivors of the stroke seek rehab services. So that need to improve. And the last slide, that will summarize my talk. It was written in Hindi. I have just, translated it. At 11 p.m., the 65-year-old man in the house lost his voice, and one of his hands and legs stopped working. The family members continue to massage his hand and feet throughout the night. So that is ignorance. Okay, they don't know what to do because they are not aware of the stroke symptoms. Upon arriving at the hospital in the morning, the doctor informed him that the blood clot had formed in his brain and would need to be removed with a wire. And the estimated cost will be 2.5 to 4.5 lakh rupees. Second part, finances. It is going to cost a lot. And there is no guarantee that he will recover. Acceptance that he may not recover. The doctor says that even if he survives, he may remain disabled for the rest of his life and will have to be cared for. That is actual scenario. And this is assistance. The patient require a lifetime assistance. And if in the last the doctor says that this facility is not available here, I can't do mechanical thrombectomy, and you have to take him to a higher center for getting the mechanical thrombectomy done, then the last part is competence. So we have to find answers to ignorance about finances, acceptance, assistance, and competence. That are the challenges that one faces in stroke management. So thank you, and that ends my presentation.
So it was a very nice talk. Now we will go for the second lecture. I mean, you put the profile of the other doctor. I'd like to invite Dr.Nufina T A, the consultant neuropathologist in the Department of Neurosciences, Dr.Rela Institute and Medical Center, Chennai. Dr. Nufina is MBBS, MD, MBBS from Madras Medical College and post-MBBS internship in Rajiv Gandhi Government General Hospital, Chennai, and MD from Christian Medical College, Vellore, and DM Neuropathology from NIMHANS, Bangalore. Teaching activities, presented seminars in the various disciplines across the pathology with active involvement in the teaching programs conducted regularly for undergraduate MBBS, nursing and allied sciences, and postgraduates MD, DM, DC, MCH, as well as lectures for the public. Brain Museum, Nimans. The specialty training is 25,000 surgical biopsies in the field of neuro-oncology, epilepsy, and non-neoplastic cases, skeletal muscle and peripheral nerve biopsies, 700 intraoperative squash cytology smears, 250 cases of cerebrospinal fluid smears, performed over 40 autopsies, presentation and awards, 10 both international and national presentations, and winner of prestigious Dr. Arundhati Thrombus Award for the Excellence in Pathology at CMC Vellore. I welcome Dr. Nufina for giving the lecture.
That was a very wonderful lecture, the initial talk about stroke, the challenges which we see in day-to-day practice as well. Without further ado, let me go into my topic. And I would like to thank the IMA Academy of Medical Specialties Coimbatore branch along with Neuroscience Forum course directors, Dr. Rajesh Babu and Dr. Vikram Subramanian for giving me this opportunity. So let us dive into the pathology of epilepsy disorders. Yeah. So what is seizure and what is epilepsy? Seizure is the transient occurrence of signs and symptoms due to an abnormal, excessive, or synchronous neuronal activity in the brain. Epilepsy is a primary disorder of the brain with an enduring predisposition to generate epileptic seizures as described here. So, according to 2014, an operational definition of epilepsy was put forth, which mentions any of these three criteria, either at least 2 unprovoked seizures more than 24 hours apart, or an unprovoked seizure and a probability of further seizures over 10 years with a 60% recurrence risk, or a diagnosis of an epilepsy syndrome. So, ILAE Commission had laid down in its paper in Epilepsia in 2017 about the different seizure types, which could be either focal, generalized, or an unknown onset. Generalized, we know the most common example of tonic-clonic seizures, an example of the motor type, or an absent seizures. Focal could be with or without awareness. It could be motor, as in clonic or myoclonic epilepsies, or a non-motor, autonomic, behavioral, cognitive, emotional, and a sensory component, which may translate into its comorbidities in later life. So with this seizure type being established, next will be the defining of epilepsy types, be it a focal, generalized, or a combined focal generalized. And this in turn may lead to a classic diagnosis of an epilepsy syndrome in a few cases. So the most important part of this epilepsy classification is that it is not only the type of seizure or the epilepsy and the clinical syndrome which is being put forth, but the etiology, which is most important to know what actually has caused which lesion or what pathogenesis has caused the epilepsy in a particular person. Now, we'll see this list one by one in some time. Before that, the basic pathogenesis of epilepsy lies in its genetic or a protein abnormality, in the various ion channel dysfunctions, or in the imbalance of the neurotransmitters or oxidative stress, primarily and ultimately leading to an imbalance in the inhibitory GABAergic and the excitatory glutamatergic transmission. So by structural, it could be an acquired cause, either as infection, trauma, or a vascular lesion like stroke, a genetic lesion as in malformations, either of the cortical development or in the vasculature. Especially these malformations, these could be an interplay between the genetic defects and the environmental influences, including teratogenic insults, which in turn will lead to a change in the cell shape, migration, proliferation, or differentiation, leading to faulty morphogenesis and resulting in malformations. There may be tumors which could lead to epilepsy, and these may be structural lesions. These may be acquired as in a de novo mutation giving rise to a ganglioglioma or any glioneuronal tumor, as in long-term epilepsy-associated tumor syndrome, or a genetically acquired syndrome like tuberous sclerosis. A perinatal insult or an insult in the early life can also lead to a structural lesion. It may be acquired as a post-infection in the infants. It may be in utero infection or a congenital infection, say CMV, or any viral infection, or a genetic cause. So these two examples I have put forth to say that not only structural, but it is actually a close interplay between a genetic and other environmental influence as well. So in tuberous sclerosis, you have a structural lesion called tubers, but it is basically due to a mutation in the genes of TSC. Similar in polymicrogyria, you have an intrauterine CMV infection which may lead to this particular malformation or a genetic mutation. We also have distinct constellations like hippocampal sclerosis associated with medial temporal lobe epilepsy, gelastic seizures associated with hypothalamic hamartoma, a unilateral hemispheric involvement as in Rasmussen syndrome. So any structural lesion, it is present and organic, and so an MRI, especially using specific epilepsy protocol, may lead to the deciphering of these lesions as seen here. Either it could be tubers or the transmantle sign and FCD, or these small cute cysts, the neurocysticercosis. Genetic could be a de novo genetic mutation in children, or it could be inherited with a family history, and where a family history comes in importance. Usually involves these voltage gated channels, the neurotransmitters, and the subunits which are involved in this. I would like to stress that a single gene can lead to a phenotypic heterogeneity, meaning it may be a mild seizure to a severe epilepsy kind of syndrome, or an epilepsy syndrome which may have different genes underlying in its pathogenesis. By infection, it may be a viral, bacterial, or the most common neurocysticercosis, which is a parasitic infection leading on to neuroinflammation, gliosis, any functional and structural alterations leading to immune response which is deficient or dysregulated, which in turn consequently results in an increase in the toxic mediators, inflammation, and decrease in seizure threshold, resulting in genesis of epilepsy. An immune-mediated pathology could result as a result of autoimmune conditions or a paraneoplastic syndrome, especially with intracellular. Either it could be a synaptic protein or the ion channels or the cell surface receptor, wherein an immune-mediated pathology and attack on the neurons lead to an epileptic disorder. Then we have the metabolic disorder, again a genetic or acquired condition as seen here, listed here, and these could also in turn lead to epilepsy genesis. So here in this talk, I would like to deal and brief upon those lesions which have been or which are amenable for surgical resection or at least a biopsy. And as a neuropathologist, I would like to share with you how these surgical specimens can be diagnosed and can lead to an appropriate answer to a patient's care. So before going on to the pathologies per se, just a quick review of embryology. We know the neural tube gets into folds, the 3 vesicles and 5 secondary brain vesicles. After having folded and convolutions, you get this good adult brain with lots of gyri and sulci. Focusing on the development of cortex, you have the ventricle zone, these blue cells, they are the stem cells, which in turn give rise to the neurons or the glia. The neurons have to migrate from the ventricle layer to the outermost part, which becomes the cortical plate. And this needs these yellow lines, the linear lines, which are the radial glia, acting as a scaffold for the neurons to move from the bottommost ventricular part to the outermost cortical part. And this is important. Along with proliferation of these stem cells which give rise to these neurons, maturation and migration occurs along the way. All this is important because every step, either in the proliferation or in the maturation or migration, and then the organization of the neurons into the 6-layer laminar cortical architecture, if any of these steps are involved, then this is going to lead on to malformations and in turn lead to an epileptogenic foci. So, having said about the vertical or the radial migration, there is also a component of tangential migration where the interneurons are going to be migrating tangentially from the ganglionic eminence. It finds its axonal paths and reaches the final destination. So moving on to the first pathology, the common pathology seen in children, especially the focal cortical dysplasia. It is a developmental malformation of the cortical plate associated with seizures. Histopathologically has an abnormal cytoarchitecture which is restricted and with preservation of gyral pattern. It is broadly categorized into 3 classes or types, type 1, 2, 3, along with its several subtypes. But if we don't find any of these, then on histopathology, we give out a report as no definite FCD on histopathology, of course, taking into account the immunohistochemical findings. So what is FCD1? It is all about the lamination which is abnormal. So as I said, this is the radial glia and these neurons have to detach from itself and then go and layer on at the specific layers of the cortex. Now, when this is not going to be detached, these are going to stick to the radial glia and form these columns called as microcolumns. They are at least 8 cells, small neurons in number. And this is exactly what is pathognomonic for an FCD1A. FCD1B is due to the tangential migration abnormality, and therefore you have an absence of a single layer or a lamination, a deficiency of a single layer. 1C will be an abnormality of both the vertical as well as the tangential cortical migration, may be very rarely seen in radiography. So FCD1 is usually not very much deciphered from MRI. This is one point to know. FCD2, at least we have an MRI positive finding structurally, and even then in FCD2A, you have at least 30% cases where the lesions are not seen in MRI. 2A is usually dysmorphic neurons. Now, these are the neurons which are these blue color substance or they are present within the neurons. They are the Nissl substance, and aggregation of this phosphoneurofilament is very typical of these dysmorphic neurons. In 2B, along with this dysmorphic neuron, you also have these balloon cells as seen here. The balloon cells are glassy, eosinophilic large cells. They are kind of intermediate between a glial and neuronal cell and has GFAP and Vimentin accumulation. Now, very typical of this FCD2B is the transmantle sign. How does this occur? This is very interesting because this is due to an abnormal proliferation. You have the cells from the neural stem cells in the ventricular zone proliferating and going above. And in FCD2B, there is abnormal proliferation. There is no stop to it. And so it just proliferates, moves up and up without any maturation. And thereby what we are seeing are these dysmorphic neurons, which are usually seen in the lower layers of the cortex. Grossly, what you find is that there is no sharp demarcation. Here, there is a normal sharp demarcation of the cortex and the white matter, the gray and the white. Here you don't have this. We have a blurring of the junction, which is very typical of FCD2B. FCD3 has a primary lesion apart from the cortical dyslamination. 3A is associated with hippocampal sclerosis. 3B associated with any tumors, especially glial or glioneuronal tumors like ganglioglioma or dysembryoplastic neuroepithelial tumor, where you can also see these microcolumns, which is the actual cortical dyslamination abnormality. 3C is associated with vascular malformation. 3D is associated with early life acquired insults, especially in the perinatal region. It could be a result of trauma, infection, or even ischemia. So here you can see, due to selective vulnerability of a particular type of neurons which are present in this particular layer, there is hypoxia, ischemia, and dropout of those neurons in this particular lamina or the layer, and that is what you call as laminar necrosis. And these rare associations of 2A and 2B with all these should not be classified as FCD type 3 variant. In the sense, all these lamination abnormalities which I have shown you here do not have dysmorphic neurons or balloon cells. It is usually the FCD1 type of pathology. So this slide is for the neurosurgeons especially, because as a neuropathologist, when we receive samples, we want as much as possible an intact specimen for a proper laminar orientation. Just now I had shown all the cortical layers from layer 1 to 2, 3, 4 until 6, and then the white matter, if possible, if there is ventricle, and then the overlying meninges. That's how we go about looking at and deciphering where exactly the pathology is and what exactly is the diagnosis. Now, when we don't have an intact specimen, when it is fragmented, it is going to be extremely difficult to give a histopathological report. And therefore, when you all give a specimen, especially of this, let's say, a resection of an FCD lesion like this, what we do as a neuropathologist is go about slicing these across the gyri. So here, to get the maximum gyri and sulcal orientation, you have the gray and the white matter, and in which you can see that there are certain foci where there is blurring of the gray-white junction, and that is the area of interest. Here you can see in formalin, you can see this is, can you see this? This is the tan color. This is the normal cortex, whereas this is pure white. So that means this is very much fibrosed or sclerosed, and thereby there is a lesion over there. There may be other coexistent epileptogenic pathologies. As I said now, any tumors, vascular malformations, metabolic disorders, or infarcts. So in this context, I would like to define a double pathology where it does not include hippocampal sclerosis. For example, one can be an FCD and one can be a vascular infarct. And those may or may not associate in the same lobe, say an FCD in the frontal lobe. And then you have a vascular malformation in the temporal lobe, in the opposite temporal lobe. They evolve from an independent pathogenesis and they may have their own epileptogenesis. We need to see which has the most likely epileptogenesis. And that's what a double pathology is. Whereas dual pathology is applied to those patients with hippocampal sclerosis where another lesion is present. For example, a hippocampal sclerosis associated with tumor or a vascular malformation. This does not come like FCD3, but it is only to patients who have hippocampal sclerosis. Apart from that, you have malformations of cortical development like a megalencephaly or a lissencephaly where you have very smooth gyri. There is no sulci, a cobblestone malformation. And we may also have mild malformations. There are structural, very explicit malformations or they can be mild malformations as seen in these heterotopic neurons in the layer 1, the molecular layer, the topmost, or in the white matter where you can see these dispersed neurons. We also have a very special entity called the MOGI, the mild MCD with oligodendroglial hyperplasia and epilepsy. It has a genetic association with this particular gene, SLC35A2, and it is associated, as the name suggests, oligodendroglial hyperplasia. There is increased, this can be visualized by IHC with myelination abnormalities. And since it's a hyperplasia and not a tumor, you have nil to very, very low mitotic activity. We may also have these heterotopias like periventricular nodular heterotopia. The reason behind this are these cells. You have the neurons which has to migrate above, but as it is not able to retract itself and go, it is going to stay over here near the ventricle zone and thereby leading on to collection of neurons periventricularly. Or it could migrate until the white matter gray matter junction, but it cannot configure itself into these bipolar cells to migrate into the cortical layers, and thereby these neurons are going to be present in the white matter as a band heterotopia. We also have abnormal proliferation and organization like this polymicrogyria, wherein you all have these detachment and termination going, but the termination does not end within the limiting membrane. It passes outside, and then there are these bumpy layers of microgyria, small and many bumpy gyri, which is present here. We may also have certain malformations like this mushroom-shaped lesion called uligyria. All these are different malformations which can be deciphered by histopathology. Moving on to hippocampal sclerosis, this may be present in young age or even in the adults. It is sclerosis, so it is neuronal, defined by neuronal loss and gliosis, mainly involving the Amen's horn or the CA sector, the cornu-aminis, sparing the subiculum, and relative resistance of CA2. I'll shortly come to this. Now, this is the chart which has been put forth in 2013-14 by the ILAE classification. So, you have this HS0, which is gliosis only. This I will tell first because this will be the control for you to know what will be the actual typical and atypical types of HS. So here you see the dentate gyrus. All this is neurons by the Nguyen stain highlighted. And you have the CA4, CA3 in the bend, CA2, and then you have the CA1, which is continuing on to subiculum. Now this is the H&E stain of the same with the control. Now what happens is in HS1, you have total or a classic sclerosis, total in the sense all the areas, the 1, 2, 3, 4, everything, the brown is lost. Only the subiculum and the dentate gyrus is thinned out, isn't it? So this is HS1. If it is sparing C2 and subiculum a little, it may be called as classic, or otherwise it's called as total. So the dentate gyrus is, this is the normal dentate gyrus. In HS1, the dentate gyrus, which is present here, is also involved. This is also involved, and you have the dispersion of the dentate granules, sometimes even leading to duplication or bilamination. HS2 is CA1 predominant. 432 is there. CA1 alone is lost. HS3, CA4 alone will be lost. That is the end folium sclerosis. Now, this is the typical classification of ILAE HS types. We have different scoring for the CA and dentate gyrus. I'm not going into the details, but what is most important is how to differentiate between hippocampal sclerosis, which is associated with epilepsy, and those which occur in the elderly, especially which may be associated with neurodegeneration and dementia, especially in Alzheimer's. So in those cases which are less likely to be associated with epilepsy, there is a non-subfield specific distribution as otherwise specified here, and extension into subiculum will be seen. Whereas in epilepsy, usually there is a sharp demarcation. It is restricting itself to the Amen horn with granule cell dispersion, which is more important and specific for a hippocampal sclerosis associated with epilepsy. Again, an emphasis on the sample which is to be sent for hippocampal sclerosis, which is very, very, very important, because only if you send an en-block, on-block resection specimen, or by slicing from anterior to posterior, you have slices like this, from where we specifically take this posterior hippocampus. You can see this nice seahorse-shaped structure, which is the posterior hippocampus. And this is all white because it is fibrosed and sclerosed. This is very important for proper orientation. Apart from hippocampectomy and amygdalo-hippocampectomy, we also get anterior temporal lobectomy. As for any other cortical lesions, you slice across the gyri to get this kind of slices. And the subpial resection is usually seen in STG, and therefore that's very easy to identify whether which lobe is actually involved, even on microscopy. Moving on to the other lesions associated with epilepsy, you have the neoplasms or the tumors, the most important of which are the ganglioglioma, the DNET or the dysembryoplastic neuroepithelial tumor, and other glioneuronal tumors, which are highly implicated in the pathogenesis of epilepsy, associated with long history, more than 2 years, drug resistance, young age onset, temporal predominance, a broad spectrum associated with CNS WHO grade 1. Now, this is just a snapshot of the few neoplasms. The ganglioglioma usually associated with BRAF mutation, you have the dysplastic neurons. The DNET, which has a microcystic change and these floating neurons. The other glioneuronal tumors, meningoangiomatosis, plenty, which is associated with epilepsy and has a diffuse CD34 expression, very easy to diagnose, provided we know where it is originating from. The diffuse low-grade astrocytomas associated with MIP-BIP-L1 genetic alterations, the superficially located PXAs, oligos, and even meningiomas. In this context, even though not a neoplasm, I would like to talk about hypothalamic hamartoma, which when resected comes as a surgical specimen to us and which can be seen as a collection of neurons with a nil or minimal proliferation index. We also have genetic tumor syndromes like the tuberous sclerosis following the mTOR pathway, highlighted by the neurocutaneous markers like these hypomelanotic macules, shagreen patch, all these angiofibromas with a typical distribution. You have tubers, subependymal giant cell astrocytoma, and other organs which are involved with specific genetic connotations. Vascular malformations may perpetuate epilepsy as a result of local ischemia, especially in AV malformation due to high-level shunting, peripheral gliosis. All this bleed can lead to hemosiderin deposition, leading to secondary epileptogenesis. The most common malformation is cavernoma, which may lead to epilepsy. Neuro-infections, especially in a country like ours, neurocysticercosis is most prevalent and commonly associated with epilepsy, especially when associated with degeneration. When it's calcified, it is just lying dormant, nothing at all happening. But when it's associated with inflammation and degeneration of the cyst wall contents, it will definitely lead to a hypercellular and inflammatory reaction, which in turn will activate the epileptogenesis. Apart from that, you have other parasites like the amoebic trophozoites, the toxoplasma, bradyzoids, and cerebral malaria with its ring hemorrhage, the viral infections, especially in perinatal. You can also see these big cells, the cytomegalo cells of the CMV, microglial nodules of HIV, even brain abscess when superficially located can cause epilepsy, especially tuberculosis in our country. Moving on to immune pathology, which is Rasmussen encephalitis associated with T-cell mediated cell injury. It's a unilateral hemispheric cortical atrophy manifesting as epilepsia partialis continua. Diagnostic criteria laid forth has histopathology confirmation in one of the diagnostic criteria. And we have a classification staging for histopathology called the PARDO. This is very important. We do get rarely lesions of Rasmussen encephalitis, and in such case, we tend to stage it to know whether it is a mild form or if it is a burnt out form, that is stage 4, where from mild, you have the mild inflammation, especially CD3 and cytotoxic CD8 associated inflammation, leading on to panlaminar gliosis and degeneration, ultimately formulation of cavity and cortical degeneration occurs. Neurometabolic disorders are important, though it may be found in autopsy point of view as infarction in mitochondrial dysfunction like MELAS, the mitochondrial encephalopathy with lactic acidosis and stroke. You may also have these ragged red fibers associated with myoclonic epilepsies and Lafora disease. Now, why is this important? Because even skin biopsies where Lafora disease inclusions can be seen and highlighted by these special stains, and muscle pathology where you have the ragged red fibers highlighted and corroborating with the clinical and genetic features, you can easily at least support a diagnosis of all these metabolic disorders. Finally, moving on to immune-mediated pathology, you have an autoimmune encephalitis or a paraneoplastic encephalitis picture. This immune mediation is the antibodies directed towards the intracellular or the cell surface receptor antigens. It could be a nuclear antigen, a cytoplasmic antigen, a synaptic level antigen, or the cell surface receptor. We have different examples for these, but I will try to explain with a usual neoplasm like an ovarian teratoma. The ovarian teratoma, once the cells die, it can lead to these antigens, which in turn will lead to antigen presentation and formation of these antibodies. And these antibodies are then going to, for example, here you have the cell surface receptors of the NMDA. We are going to link this and then lead on to pathogenesis and functional alterations of this biochemical change. So this particular encephalitis in immune-mediated pathology, though not surgical pathology, as neuropathologists, we ask for CSF and serum, go for cell-based assays like this, see under immunofluorescence microscope, for example, who is associated with carcinoma lung, NMDA receptor is associated with ovarian teratoma, and we categorize and say that these may be positive, and if these are positive, then a particular carcinoma may be associated, and advise for PET-CT and other biomarkers, tumor biomarkers. Not only immunofluorescence, we have blots like this, which can specify which protein or which antibody is involved. So finally, we may have any initiating event which may lead to repair and no consequence. But if there is failure to repair of infection or stroke and leads on to epileptogenesis with its severity, the epigenetic changes and the comorbidities, resulting in any structural or functional alterations like inflammation, blood-brain barrier, or even a neural circuit change, this may take from weeks to months to years, leading on to cognitive, behavioral, or autonomic disturbances, translating to the comorbidities, or establishing late seizures, progressing and leading to chronic epilepsies. Either go for targeted therapies or symptomatically treat with drugs. Infections can be treated by targeting the infectious organism. And when all these are going to be drug resistant or not pharmacoresponsive, then what we know is that this should be surgically resectable. You may have a structural lesion which in turn will lead to an ictal or a semi-symptomatic zone. This blue is the epileptogenic zone. But like a stroke, where you have the core and then the penumbra, you also have the irritative zone in epilepsy, from where your biochemical changes are going to spill on and expand to the neighboring cortex. And when we get surgically resectable or biopsy or pathology, what as a diagnostic neuropathologist, we try to give as much as possible the specific and patient-oriented and therapy-directed histopathological report for appropriate management of the patient. So that is about my talk. Thank you for the opportunity again. Any questions are welcome. Thank you.
Oh, it was a very nice, exhaustive presentation, madam. So I invite Dr. Vikram sir to give the vote of thanks.
It was a great session by two of our wonderful speakers, Dr. Deepak sir and Dr. Nufina. Both gave an extensive talk on their fields, which is definitely useful for our general practitioners. Thanks to Neurosciences Forum for and the East West Pharma for helping us to run this webinar consistently every month. Thanks to various speakers. And moreover, I think this time we had a participation of more than 300 people, and hope it benefited some of them in their knowledge as well for their clinical practice. Thank you, IMA AMS and IMA Coimbatore for helping us to do this. Thank you, one and all. Thank you, Rajesh sir. Thank you, madam.
Thank you, sir. Thank you.
Thank you.